had a few good questions during the break, even though we still have another hour, 2 hours. I'm going to present for another hour and a half, and then Maggie's going to come back and present on how to export data. But I did want to give you 2 points, because one of which I might not come back to. If a patient has you get their ICD-9 codes back, and what you see is 2 colo codes, different codes, but they're both in the colo group. That's one colo procedure. Do not put in 2 colos. That's true for any time you see multiple ICD-9 codes that fit into the same NHSN operative procedure code. That's one procedure. They just happen to do 2 things that both met colo criteria. And again, I am a broken record, I know. That is in your denominator reporting instructions. Okay, so let's go ahead and get started. So there are a few procedures that have some additional fields that you get to have to put some denominator data into. And there's 5 procedures that if you're following these in your reporting plan, there's extra fields. That's C-sections, which has been true for quite a while, your fusions, refusions, H-pros and K-pros. All of these have a little bit additional. So for C-section, you're going to need to put in the number of hours they were in labor in the hospital. You don't, the length of time from the beginning of active labor as an inpatient to delivery of the infant expressed in hours. And if it's less than 30, run down, greater than 30, round up. If there's no hours of labor like a planned elective C-section, it's 0 hours. And you just need to check for documentation in the chart. And this can be defined as active labor, however your hospital policy is doing it. We don't micromanage this data field, but it is something you'll need to know. Fusion refusions have, again, 2 areas. The first one is you're going to tell us at what level the procedure was done, and then the approach. And some people have said, oh, what if it's anterior and posterior? Remember, we have a field for anterior and posterior. When they're both done, you'll put that in. And if they do it at multiple procedure levels, if it somehow ends up actually crossing into atlas axis and atlas axis cervical, you do the area, choose the one that had the most number of vertebrae fused. And in our, because I just answered this recently, people say, well, how do I know which this is? In our table of instructions, again, broken record, we have the exact different spinal level cervical vertebrae named. We say, you know, with atlas axis goes this through this through this. So we really tell you exactly which vertebrae are included in these groups in the table of instructions. We don't have unknown anymore. If it's unknown or not listed, you're going to need to obtain information for that procedure, you know, and usually you'll have to just read the op note and they'll say it. If they didn't, I would just really base it on what the ICD-9 code is. Some of the ICD-9 codes will actually say this is a cervical fusion. If they didn't note it, you can use that as well. We used to have a lateral transverse code, and that got replaced by transoral because it's more the terminology. If you actually go into the current ICD-9 code book, you won't find that lateral transverse listed. It's now, you'll find transoral approach. All right, forgot I had all these pop-ups, but I've told you all that. All right, now hip arthroplasties and K-pros, H-pros and K-pros have some additional fields. They've always had additional fields, and they have a few more this year. I do want to get a show of hands. How many of you are reporting H-pros and or K-pros right now? Huge number. Wow, okay. That's 90% it looks like. So, I mean, that's a very high number. I did not expect that. Okay, so I may spend a little more time on these next couple slides, and I will tell you this is a little confusing right now with ICD-9 codes, and so I am going to just open myself to saying, please, if it doesn't make sense here, you can send me questions in the NHSN mailbox. So what we did, we provided this for you. One of the sort of experts here at CDC is a orthopedic surgeon, and she was really, really sweet because I said, you know what, we're IPs, we're not surgical nurse, we're not orthopods. Sometimes when someone says it's a total primary, like, what does that mean? So this is her best at, can you put them in little tiny short sentences of when we're saying something's a hemi-partial revision, what does that sort of mean in just easy lingo to understand? So I think I've shared this with a couple people via the mailbox, and they found this to be very helpful. So I'm just providing this sort of real-life language of what these mean for you, okay? And there's also some really good resources that she included that she thinks, if you want to know more about what hip resurfacing means, she put in a link for that, hemis and total. So she was very sweet to provide this information. Now for K-Pro, she did the same thing, gave some good resources for us to use, and kind of gave a description of what this means when you see someone's had one of these. And again, you all could have probably gone to your orthopedic advanced practice nurse, you know, that you have, or someone and gotten something similar, but I wanted to provide something. So because we had these fields and people were like, well, what ICD-9, if, you know, how do I know what this is? So if you're manually reviewing, you can read it and try to put it together yourself, but if you're using ICD-9 codes, we provided for this because it was confusing, and this came out in a newsletter. It's in your all's newsletter box. We provided a mapping tool if you were using ICD-9 codes to help you just select these boxes you're going to see based on what the ICD-9 code that came across. So unfortunately, manual chart review or direct entry into the OR database would be to be required to correctly specify these for the H-Pro and K-Pro can be difficult due to, and this is the key word, the lack of specificity of ICD-9 codes, CM codes. They just don't map one-to-one. They don't. And if you could really tease out and read in detail every op note, maybe you could figure out what they're doing, but everybody doesn't have the ability to do this. And the good news from everything we've heard is that ICD-10 PCS coding is much more granular and more specific, and hopefully we won't have a thing where, yeah, every 81, 80 to 8.00.81 to 00.84 is a K-Pro hemi partial revision. So we're gonna see. So what we did is we told you these are your K-Pro fields, and if you find, and you want to use ICD-9 codes, if you find an 81.54, you will call that a total primary, okay? Because you have to first collect total, then total primary. And you know, you can see all these, and if you find anything that's a 00.81 to 00.84, that's a hemi-partial revision, anything in that code. So we're hoping these will help you, and this is in an NHSN newsletter that was sent to everybody, just for this mapping. And you should be able to find it in your mailboxes if you forgot to open that one. I know we get busy. We did the same thing for the H-Pro mapping. These are the different possible fields that you could use for ICD-9 code mapping for these new required fields. And you'll see them all listed here for the resurfacings, the hemis, the totals. Now this is where in this orange note, I want to give you a note, and this will make a little more sense, I think, when Maggie then talks if you're using CSV files. Due to a defect that we're going to be correcting when NHSN goes to from ICD-9 to ICD-10s, that 00.71 and 00.73, see they're in this hemi-partial revision? They really are hemi-partial revisions, those codes. If you're uploading this via like a CSV file or you're entering ICD-9 codes, when you go to import that, you're going to get an error message that that code doesn't match for a hemi-partial revision, but it is how we want it coded. So 0071s and 0073s, we prefer you don't use an ICD-9 code for those and just name it as a hemi-partial revision, okay? Then you will not get that error message, and it's all here. You know, it just says leave that code field blank and just select that it's a hemi-partial revision just for those two codes, and this will all go away and be fixed when we go to ICD-10 codes. So in summary, complete and enter or import a denominator for procedure record for every NHSN procedure that's performed and selected for surveillance. Use the SSI protocols, your table of instructions, key terms, and chapters from the patient safety manual. Now we're going to go briefly to linking a procedure. So you've got all your denominator data in there for the month, and now you're doing spectacular surveillance, and you're out there finding your SSIs, and you want to link these two together. It's basically telling you this denominator, this procedure done on this day, I now have an SSI on this day. And as Maggie said, it's procedure-based. That SSI may have occurred in March. The procedure was in February. It's going to show up as a February infection. It's linked to that in terms of your SIR analysis, even though, because that's the denominator, is the day you do the procedure. Linking's really important because it gives you the correct risk factors that were matched very specifically for that SSI. So all those risk factors are in there. So first you enter the denominator. You don't want to put in an SSI if you haven't gotten your denominator data in yet. If you found the SSI for some reason and you haven't done any of your just hold it back for a little bit and make sure you've got your denominators. Then you're going to enter the SSI record and you're going to link the two. Now this is something I really want to emphasize how important this is, and it'll make your life easier and you will get less error messages, because I made this mistake many times as an IP myself. If I forget and I start going in, oh, I've got my SSI, let me start entering all my data, I enter it all, and then I say I'm going to link this procedure, and I get this big error. The procedure is not found. And I'm like, wait, I know I put that procedure. Try again, still. You don't want to enter any of your SSI data into this, okay? Just get the patient's name, go link an event. You're going to put in that you have this SSI. See, all I have filled in here, let me use my mouse, is that there's an SSI, and I'm going to link it to the patient's. You do have the patient's ID up above. And then when you link it, you're going to click that button, okay? And then it's going to send you to the procedures that patient's had. Don't put any more in than that. You're going to select this procedure next to the colo, and you're going to hit that link button. And then when you go back, it's going to send you right back to that record, and it's going to have filled in the stuff that you put in before. Because if you have the tiniest little mismatch from what you put in there in that denominator data from something you go forward and put in your numerator, you'll get that error message that we can't find that procedure because they don't match exactly. That will help you a lot. See, there you go, and then it auto-filled this. So now all the data are linked together and they're exactly right. They're not mismatched at all. Then you click don't forget the save button. Now we're getting into the meat of it. A couple of people were asking me, like, I said, no, we're gonna cover the SSIs next. So now, superficial SSI. This, because very few of you are brand new, I am not going to read every definition. I'm going to highlight the issues, the concerns that happen, and point out what's different. So remember, colo and HIS procedures are both 30-day procedures. So for those, they never go up beyond that. And I want to tell you something, because I was giving a training for some of our state health departments a couple months ago, and they are finding facilities that think because CMS just gets our deep incisional and our organ space infections, that they can completely blow off superficial SSIs, not look for them, not report them. Well, when you look at what you do, when you agree that you are an NHSN facility and you have your certificates, you agree when you sign up to do something that you're following the protocol. So you are supposed to be doing superficial, deep, and organ space. It's just that we only send the deep and organ space to CMS, but there was never anything that said don't look at superficials, at least not at this point. We haven't gotten rid of that definition. And we did not really change anything with superficial SSI, except it is the only definition that still has diagnosis of a superficial incisional SSI by the surgeon, and you'll see that that was removed for deep and organ space. Now this is a new, I want to go back one more. No, I get to that. I get to that later. Okay, so this is the newest reporting instruction. Someone asked me about this before the lunch break. This has really been simplified. So in the past, we had a lot of little funny rules. If something is a deep If it meets superficial, deep, and organ space, you should split the difference and call it a deep. If something is a superficial and organ space, and you actually find the organ space is draining through the incision, then you call it deep. And there were a lot of little funny rules about splitting. We got rid of all of those. You simply call the infection at the deepest level that it actually went to within, it's a key word, within the appropriate surveillance period. So if you write a superficial SSI up on day 20 after a hist, and then the patient comes back in on day 40 and it's progressed to a deep, you do not upgrade that you did not meet the definition of a deep incision in the 30-day surveillance period, okay? That really drives everything. If you try to enter a superficial SSI beyond the 30-day period, this is where we talk about the application, the business rules behind things. We try to make the application. Some people have been asking about validating. How do you know it's the right data? You're going to get an error message that says this, because you've already said you're sending us a superficial. And if it's beyond the 30-day period, you're going to get an error message, and it won't specifically tell you why, but it's going to say it doesn't meet definition. So stop and look, because sometimes it just falls off our plate. You know, you're busy. It's like, oh, I didn't even notice this was day 35. That's why I'm getting that error message. All right? Now, I do want to point out, look next to the 90-day surveillance period. This is just cut from the protocol. Over here, you'll see the note at the bottom of this page. This is table 3 from our manual. Superficial incisional SSIs are only followed for 30 days for all procedures. This is another question we get. Someone will be reporting, they'll say, oh, here's my 90-day surveillance categories, okay. So we got rid of implants. Remember back in 2012, if a patient had an implant, yay, you guys are still happy. You're still happy about that. Remember back in 2012, you had to look for every little internal staple and implant follow for a year. That went away in January of 2013. So it doesn't matter if they used an implant in that procedure or not. You can have breasts or in the 90-day surveillance period, and the breast with an implant, the breast without an implant. They're all followed for 90 days. But this note down here is telling you no matter what, for all of these categories, superficial is only ever followed for 30 days. So I've had people really get confused because they're ending a superficial SSI on a breast procedure, and they know that's a 90-day procedure, and they don't understand why. You're going to get that same error message because you can only report the superficials. It's the deep over here and the organ space that you can follow for the beyond 30-day and up to 90-day period. So a couple little reporting instructions for superficial SSIs. Do not report a stitch abscess. Now, I'm going to define stitch abscess because I have had some surgeons' notes copied to me where you've got a person with a huge abscess in their muscle, and they say, oh, that's where a stitch was. I'm like, no. That's not what we mean by a stitch abscess. We mean, and I've had some personally myself, it's where the suture, the staple enters the skin, and you get a localized little abscess at that external lateral position. That's what we define as a stitch abscess. Those should not be reported as SSIs. They don't meet our criteria. Also, don't report a localized stab wound. Now, someone asked me, they thought this meant like from a street fight. I'm like, no. Those might get infected, but they're also not no, we mean when they make a stab wound to put in a JP or something like that. That's what we mean by a stab wound. So if they have done a stab wound to insert a drain and you get a localized infection of the skin around the stab wound, that is not an SSI. Now, if you're Pennsylvania, they must feel like we're picking on by now. That could become a skin soft tissue, just non-SSI skin soft tissue infection it may meet, but it shouldn't be reported as an SSI. And that's what I say there. And the last one is a little messy, but it's cellulitis. So here's where we go with physician diagnosis. I'm going to give you 2 examples of physician diagnosis. You have a patient that literally, let's flip back to our definition of a superficial SSI for you here. You have a patient who comes in, and the only symptoms they have are redness and a little redness and some warmth. That's it. It's looking a little angry. But that's all you've got. That's a cellulitis. There isn't drainage coming out of it. The surgeon isn't opening it and doing anything fancy. You've just got that. The physician calls this SSI and treats them. That does not, what supersedes is the fact we don't want you reporting cellulitis as alone. So if the physician treats a cellulitis, that doesn't mean you now do criterion D. We don't want you doing that. That's a reporting instruction. What we would have to report, and they're saying, well, what would we have to report that the physician would call an SSI? You could have a patient who has a lot of serous drainage coming from their superficial incision. Look at this, A. It's not purulent, but it's really a ton and it's serous. And the physician calls that an SSI and treats it. This is where physician diagnosis would come in. You would call that and you'd use criterion D. We don't see it having to be used a lot because usually they'll meet with some other reason, okay? The other one I want to talk about, and man, I hope I can finish this. I'm going to have to start talking fast, is I get a lot of questions of what do you mean by an aseptically obtained culture? Basically, if that culture arrives to your lab or the lab that you use, and that lab accepts that culture, and that culture comes back with an actual organism identified, it isn't mixed skin flora, it isn't mixed flora, it isn't mixed cutaneous flora, it has an organism in it. You assume that your facility obtained that properly following proper policy and procedure for how your lab and your facility wants wounds collected. If you think your facility is not following proper technique for collecting wound cultures, that's an educational opportunity. But you can't just look at things and say, I don't like how that looks. I don't think that was aseptically obtained. That's not your call. You have to trust that your lab runs proper specimens. The ones that weren't properly obtained should be coming out as mixed cultures and just a bunch of junk, and those don't meet our criteria, okay? So I want to address that. And then the last one I want to address, and a lot of people really get this, is criterion C. So you can have a patient who comes in with a really red, hot, angry-looking wound. The surgeon wants to know what's going on underneath it, or the ER physician, and they actually open the wound. It is deliberately open. This is no spontaneous dehiscence in here. They deliberately open it, remove a couple staples, and a bunch of stuff drains out. They poke around, they look, and they do not get a culture. They say, I'm not culturing, I'm just going to open this thing up and drain it and do whatever. If that patient came in with these wounds, pain, tenderness, swelling, there's some reason that physician decided to open up that incision, and they choose to not culture, this will meet criterion C. If they do that same thing and they get under there and they're like, ooh, I think this might be a seroma, and they culture it, and it's culture negative, you don't meet this criteria. A culture negative finding does not meet this criteria. If they get in there and there's this icky, thick, blackish looking stuff and it looks like it may be an infected hematoma, and they open it and they drain it and they send a culture and it's positive, that's an infected hematoma. I get that a lot. Is every seroma infected? No. Is every hematoma infected? No. But this is how they're often found, is right like this. So I just want you to be clear on that no culture done versus a negative culture versus a positive. Okay? And spontaneous dehiscence, which will show up in our deep incisional, doesn't show up here. And I think it's actually because there's a lot of superficial incisions that will spontaneously dehisce a little bit. You know, they'll have some issues. But we do have spontaneous dehiscence in deep, because you really don't, if a deep wound, for it to spontaneously dehisce to the deep level, that's a major thing, versus a little superficial dehiscence, which is but for the superficial, it has to be deliberately open to meet that specific criteria. All right, so you can have both a superficial incisional primary, and I'll use the cabbages as an example for that, the CBGBs, that if your chest incision gets infected, that would be a superficial incisional primary. If your leg incision gets infected, that's a superficial incisional secondary. We only have a handful of procedures that have two separate sites set up, but you'll find that in your drop-down menu. You'll be telling them, am I writing up the SIP or the CIS, okay? And so that's what you would do with those. And if a patient has both, and they develop an infection of their chest site way up here, and they have an infection of their leg site, you're putting in two SSIs. They've got a CIS and a SIP. So here's an example. I'll get you. This is not your clickers. It's just follow along. A patient delivers a baby by C-section on August 23rd, and on her first postpartum visit to her surgeon on the 20th, she noticed yellow purulent drainage in the superficial incision. Does Gretchen have a surgical site infection? I'm hearing lots of yeses. Yes, that's purulent drainage. That's criterion A, okay? Is it a superficial SSI? At this point, from the knowledge we have in front of us, yes, it's just purulent drainage coming out of that superficial incision. Is this a SIP primary or is it a CIS secondary? SIP, you guys are good. It's a SIP. She didn't even a C-section doesn't have a secondary site. So here's another example. If a patient underwent a coronary artery bypass graft cabbage, the surgeon got the donor vessel from a site in the leg. 5 days post-op, the patient has pain and edema in the leg incision. They open the superficial incision, drain the pus, irrigate the wound. Does this person have a superficial incisional SSI? Yes. Is it a CIS or a SIP? Right, the secondary site, CIS. Let's do another little case. You'll need your clickers for this, so share if it's someone who hasn't had a chance to use it. So 218, you have a 45-year-old male admitted, and he had a laparoscopic left hemicolectomy. That's 1735, and that's a colo. 3 trocar sites were closed. In the 4th site, they used to place a JP drain. And then on 224, that's about a week later, you have purulent drainage noted at one of the trocar sites. The culture is obtained and is positive for Intraabdominal species and E. coli, and the patient is started on antibiotics. Is this procedure considered a primary closure for 2014? Got some voting going? 10 seconds. You guys are so fast with those now. Yes. It is. Remember, you closed, all those trocar sites were closed. And if you have someone, I'm going to just tell you this because I'm not sure it's as clearly expressed in our current manual as it was in 13. If you have someone that has 4 trocar sites and they close 3 of them and leave 1 open, and they just don't close it, you still have a if any of multiple incisions, when you have a procedure that has multiple incisions, like laparoscopic procedures, if one of those is closed primarily, it's considered a closed operative procedure. Primary close. Very good. Case 5, the rationale they're using for this one, the surgeon was just using that existing trocar site to place the JP drain rather than creating another stab wound. And if there are multiple incisions and one of them is closed primary, the whole procedure does meet criteria for a primarily closed procedure. What should be reported to NHSN? Well, nothing in terms of that, the surgeon did not open the wound, so the criteria are not met. Nothing, it's an SSI but not an HAI. It should be a superficial incisional primary or a deep incisional primary. You can look back at the case. I'll give you about 10 seconds, lots of votes coming in. All right. You guys are good. Superficial incisional primary, and I'll show you, we'll go through this so you can see why. It happened within 30 days. It was only the skin and the subcutaneous tissue, and you had purulent drainage at that trocar site. It was superficial. And there was an organism that was cultured, obtained, and was positive. So a lot of times you'll meet more than one criteria in an SSI definition, and that's fine. It's not like when you go to enter it, it's asking, was this A, B, or C? It will meet criteria. Let's try another one. Let's go on to something that isn't a colon or a HIS. So this patient has a hip arthroplasty, especially because almost all of you are following hips or knees. And it's performed on 3/17 at Hospital A. They get discharged on 3/19. That's pretty darn fast, but they get them out quickly now. They're readmitted to Hospital B on 3/25 with purulent drainage from the superficial incision. And further investigation at that hospital concludes this is a superficial incisional SSI. What should Hospital B do? This is not clickers. This is just... Exactly. They need to notify Hospital A about the SSI and give as much information as they can And what should hospital A do? Exactly. They need to report that SSI to NHSN if it's in their hospital reporting plan. Hospital B doesn't know if hospital A is following HPROs or not. Give them the chance to know this happened. And they're going to report it because they're the ones you have to think is procedure-based. They're the ones that have it in their denominator data. I get questions from rehab facilities and stuff saying, well, they were fine when they left and then they went to rehab and now they have an SSI. That doesn't seem fair that I have to count it. I'm like, well, the rehab can't count it. They don't have the denominator data and it wasn't there. Again, you have to kind of get your brain around that this is very procedure based. What if this same infection, this HPRO, met criteria on day 35, post-op day 35, what would you do? Right. It's not an SSI. They have an infection, but it doesn't meet SSI criteria and it's not reported. They've been gone forever. You know, they've been gone for over 10 days from your facility. It isn't anything at that point. SSIs are always associated with that particular procedure through linking. And if you don't have that procedure in your database, you can't link that infection to it. And you only follow your superficials for 30 days. Let's try case 7. So this is a 70-year-old male who was admitted on 3/10 and underwent a hemicolectomy and a repair of an abdominal wall hernia via the same incision on the day of admission. The incision was closed and a JP was placed via a stab wound in the left lower quadrant. And the patient went home about 4 days later on the 14th. Then 3 days later, that patient arrives to the ED, has a red, painful incision. The incision is draining yellow, foul-smelling discharge from the superficial incision. The physician removes 2 staples, so you see these cases all the time, probes the wound. The fascia is intact, and there's only subcutaneous tissue involved, and no cultures were obtained. Antibiotics are ordered, the wound is packed, and the patient is discharged home from the ED. You've seen these cases. This is definitely, we see these after this. So, what should be reported to NHSN? Nothing. The wound culture was negative, so it doesn't meet criteria. Nothing. He had 2 procedures, so you don't know which one caused the infection. Valid point. It should be an SSI SIP attributable to the colo. It should be an SSI DIP attributable to the hernia. All right, start those buttons going. Little tougher one this time. I'm sort of testing you on something I haven't taught you yet, but you guys are very experienced, so I'm sure you'll get this. All right, 10 seconds. I've got almost most of the responses. Finish it up. All right, let's see how you did. Oh my gosh, look at you guys. All right, okay. There was only maybe one person that said 1 and one said 2. Okay, it is correct. This is a superficial incisional primary attributed colo, and here's why, because we're going to go over that now. If more than one operative procedure is done through a single incision, first attempt to determine the procedure that is thought to be associated with the infection. So for example, here's where one you could. If a patient has a CBGC, so just, and had a card done at the same time, and they come back with a valve infection, it's an organ space valve, then the SSI should be attributed to what? The card. I mean, you can tell sometimes when you're dealing with organ space which is the culprit, so to speak. If it's not clear, which is really the case, almost really is the case with any incisional SSI, superficial or deep, you're going to use the NHSN's principal operative procedure selection list to determine which of those procedures is higher risk for getting, because we've looked at this. We said which procedures, and we rebaselined that list last year, and it changed things around quite a bit when we did that. So there's 5 lists that are in Table 5. This is Table 5. You have your abdominal operations linked all together, your thoracic. We combined neurosurgical operations of the spine and brain together this year because the risk worked either way, so it didn't make sense to keep it a separate list. It won't change your data. They lined up exactly. It just was kind of confusing to have them separated. And the neck. And the categories with the highest risk are listed above those with the lowest. So we use this a lot. So if you look at this, that person had a colo and a hernia. Well, hernias are way down here and the colo is way up here. And it was incisional, so this would be attributed to the colon. Man, I think I had something with lunch. Okay, let's do deep incisional SSI. And for this one, I put a little post-it note to remind you of the only thing we tweaked on this, same thing you've been looking at for the past couple years, is that we did remove MD diagnosis from deep incisional SSI. Okay? So you're going to need to meet this criteria. So, and again, this is pretty clear, purulent drainage, but again, remember, we want them to be saying that this drainage is coming from the deep area. That means they somehow have enough knowledge, and often it's because they've had to open it, that this infection is down in the fascial muscle layer. Or that, now for here you can spontaneously dehisce, but what they're saying, again, the key word here is a deep incision. So when it opens up, they're like seeing the fascia muscle. It really opened up. It was a bad dehiscence, or it was deliberately opened. And this is the same again. And it is culture positive, or they choose. Now this we see more rarely. If it's to the level that a person's literally, they've opened up to the deep level, a lot of times they're back in the OR, but they're usually, they culture to see what's going on. And you do have to have some kind of symptom here, but fever, and it's just localized pain or tenderness, and a negative culture, again, will not meet this criteria. So it's very, very similar to superficial, but here you can have a spontaneous dehiscence or deliberately open. And the last one is that they just really observe in that area the deep incision on direct exam, means a physician looks at it and sees what looks like an abscess, purulent fluid, whatever, in the deep area during an invasive procedure or by histopath or imaging. So the invasive procedure here could be that they actually take the person down to CT. It doesn't mean they have to go to the OR, and they drain an abscess that appears based on the imaging they did of it, and when they go down, that this is still localized to that muscle fascia layer, okay? Very similar, you have the primary and the deep, primary infections or secondary sites. Exactly what we just talked about for superficial pertains to deep. So let's try another case. So you have a patient is admitted to the hospital on 3/12 for an elective surgery, and you do have an active MRSA screening protocol at your facility, and so you screen everyone's, do a little nary swab on admission, and they are MRSA positive patient. On the same day, the patient undergoes a total abdominal hysterectomy. The post-op course is unremarkable, and the patient is discharged on 3/15. 3/18, the patient's readmitted with complaints of acute incisional pain since the day before. The surgeon opens the wound and notices the fascia is not intact. Now that thing that I'm saying, you're saying, oh, they don't do that. They do. Surgeons very often will really note what's going on with the fascia. That's a big thing for them. Has this gone deep enough that it's into the fascial layer or not? When they say it's intact, they're telling you it didn't cause anything there. It looks good. So that's a key. When you say it's intact, that's a key that you're probably dealing with something that's gone to the level of the fascia, but it's intact and not affected. Once you get into the fascia muscle, then you've got the deep infection going on. And they send a specimen from the deep wound, and on 3/20, the culture results are positive for MRSA. Is this an SSI? Yes, it meets criteria, or no, that patient was colonized with MRSA, so this is a POA. Yeah. So, surgeons might want to pull that one, but it doesn't fool us, right? So I figured you guys were too smart for that. All right. Still, I see the votes coming in, but let's go ahead. Yeah, guys, you nailed that one. All right. We've all heard it, though, right? Yeah, so, that's why it hits home. What infection should be reported? Look back on that case. Is this a SIP, superficial incisional primary, superincisional secondary? Man, these are tongue twisters. Deep incisional primary, deep incisional secondary, or is this maybe an organ space SSI intraabdominal infection? So go ahead and start your clickers. All right, give you about 10 more seconds. I think everyone's voting quickly on this. Exactly. It's a deep incisional primary. The fascia was involved. They were in the deep area when they got the culture result. And here you are. Which one did you hit? You hit that one we talked about. They opened the incision. They deliberately opened it. It was culture positive, and she had increased acute local pain that from the day before. All right, and very good. All right, different scenario. Let's take this and change it up a little bit. It's still the same patient. She still came in for that elective surgery, still MRSA positive, has the hist on the same day. The post-op course, she's still discharged on the 15th. She comes in on the 18th with complaints again of that acute incisional pain. The surgeon opened the wound, clear serous drainage is found, and notes the fascia is not intact, sent a specimen from the deep wound, and on 3/20, the culture results come back as final and no growth. What infection should be reported? A superficial incisional primary, a deep incisional primary, an organ space, or nothing. It's not an SSI. Go ahead and pass your clicker to someone who hasn't gotten a chance to vote, or vote. Give you 10 more seconds. All righty, let's see if you got this one. Very good, that's correct. Nothing, it's not an SSI, and I'm going to show you why. Here we go. They did deliberately open this. She had some pain. What came out was a lot of serous fluid. Maybe think of what sometimes causes serous fluid, seromas. And it was culture negative. They cultured it, but it didn't grow anything. So this is probably someone who had a non-infected seroma that they drained, okay? So those are often found in that area, okay? Makes sense? All right, now we'll get into organ space. Again, now what we did is we removed MD diagnosis has been removed from organ space. Now what I want to try to kind of map out for you on my hands here is, so you've had your SSI chapter, you've got your superficial, your deep, and now we're moving on to your organ space. And then you have, that has to pair with organ space, your chapter 17 definitions of site-specific infections. You have to meet the one to start looking at the other, okay? And because we removed, and I just want to clarify this, diagnosis from this, it's thrown some people off, and I'm going to give you an exact example, is that you have to meet one of these, okay? Purulent drainage from a drain that's placed into the organ space, okay? Organisms isolated from an aseptically obtained culture of tissue or fluid in the organ space area, or an abscess of, and this is this huge general statement here, or other evidence of infection that's detected on direct exam, or during an invasive procedure, or by histopath or imaging test. This other evidence of infection is a real catch-all. I have had concerns expressed to me of, oh my goodness, we will never be able to call another post-C-section endometritis because you removed physician diagnosis. And I said, no, no, no. And we're rephrasing this in 15. It's going to be a much better phrase. We're going to say, no other evidence of infection on gross anatomical exam. Okay? So what happens when you have a patient who comes in, they've had a C-section, they come in febrile, tender. The physicians are usually palpating the fundus, and it's very, very tender. The physician at that point is like, oh my gosh, I think we've got an endometritis. That is that other evidence of infection. And then you then go and see if that patient actually meets your endometritis definition. So I want to kind of explain that C is a huge category that is basically saying this has started a surgeon on the path of looking at what is going on with this patient. And now when you don't have like frank purulence or a drain put in or an abscess that's obviously seen on CT, that lets you go down the path to see if it ultimately will meet. We do have, so the specific sites of infection that you can use after SSIs are listed here, and we do have a new definition added. It didn't replace one. We still have joint infection down here. Oh, get this little, please, where did my mouse wake up again? Oh, it moved over here. I'm like, that's where it went. Okay. Joint infection still exists, but it isn't if a person has a prosthetic joint in place, okay? If they've done a H-Pro or a K-Pro and you have had a H-Pro, K-Pro procedure, for H-Pros and K-Pros, you use this new PJI definition. And if you are a place that follows everything and you just had sort of like a wrist surgery that got infected or an ankle or something like that, joint still exists for that, but you won't actually, under H-Pro and K-Pro, when you look at your drop down now, you won't find joint listed anymore. You'll just find PJI, okay? And we're going to cover that briefly. We can't do it in detail, but because a lot of you all are following hips and knees, I want to, give some time to this. So number one, I will tell you right up front, you will be calling less PJIs than you call joints. Your numbers are going to go down. It's the kind of thing to note in your infection control committee minutes. I don't know if you keep little magic arrows of timeline of this is when something changed. Because think about our old PJI definition. You could have a single coag-negative staph that grows in broth from an aspirate of actual joint fluid, and that met our joint infection, okay? And this new definition was done after much, much, much work and a huge conference of the MSIS, which is the Musculoskeletal Infection Society. And then we worked in collaboration with them, that's new harmony we're talking about, to really get a definition that I think our orthopedic surgeons are really going to respect. But I think, and hopefully you all are all going to your OR committee meetings when they happen once a month, this is something you need to take to your OR committee meetings, and you need to educate them that we have a new definition for our joint infections. It's based on your societies, the orthopedic surgeon, the musculoskeletal infection societies definition. This is almost identical to their new definition. So it should make your orthopedic surgeons very happy, but they need to be informed, because if they have a little less than maybe, I want to say this correctly, if they're possibly not following best practice for what you should do to rule out that you have a true joint infection, them knowing what's in here may change that practice. And a big one be the fact that you're going to need 2 positive periprosthetic, that's your tissue or fluid down at the level of the joint, cultures with identical organisms. Not the antibiograms don't have to match, just you're going to have Staph aureus in 2 cultures, or you're going to have Staph epidermidis in 2. They have to be matching and identical. And before a single culture could buy you a joint infection. The other, and any of us who've worked a lot with hips and knees know that sinus tract, and the slide would have been insane, but there is a definition of what a sinus tract is in the new PJI definition, but what it comes out is when the patient presents, it looks like they have a little defect in the incision and pus is like coming out, and then when they take them back, they actually find that this tract of pus that's coming like right from the knee joint and exiting out of the incision. That's called a sinus tract. So if they just see that sinus tract and they didn't even get any cultures, and they take the OR and they're like, you see that keyword, oh my gosh, they have a sinus tract, that will meet PJI definition. Or, so here's where you get where there's less evidence. Here's where you have a single tissue or fluid here. If you have a single, you're going to need some other blood work to be done. And on the form, you're just going to click off when you enter it, other positive lab tests, because these all fit that criteria. You're going to need to see an elevated C-reactive protein or an elevated ESR. Both of these are indications of inflammation in the joint. So that's a key one. And this is my last correction. It was a typo. It was not there originally, but sometimes our manuals do a little magic thing. This was a C-reactive protein, came over as 100. That would be like saying a patient has a fever of 370 degrees. You will never see a C-reactive protein of 10. It was 10 is what it is. So it's corrected here. It is not corrected in the manual yet. So it should be 10, not 100 there. Then you're going to also have WBCs, see elevated WBCs in your synovial fluid would be B, or this is a new practice they're doing more. They're literally doing like what we kind of do on urines. They're doing a leukocyte esterase test strip, and if it's a leukocyte esterase positive, if you have a practice that's doing that, that will also meet B. And then the last one is you have greater than 90% PMNs showing the fluid. So we're looking for infected fluid and a single positive. But any of these, 3 of these 5 will also buy you a PJI definition, okay? If a patient has an infection in the organ space that was being operated on, I think we've covered this enough, and subsequent continuation of this infection type during the remainder of the surveillance period, it is considered an organ space SSI if the organ space SSI and site-specific criteria are met. Again, you can have a patient, it's not like you open somebody up and say, oh, they ruptured their colon, let's just leave it open. They do everything in their power to clean out that patient. They do colectomies, they might form a colostomy, they throw antibiotic washings numerous times, and they give them usually extended antibiotics. They are doing everything they can to prevent that patient, but we know those patients that are wound class 3 and 4 are at very high risk of getting SSIs, and that is calculated in your SIRS in the data that's sent over to us. And it's even going to be doubly calculated, and we'll be able to see what's happening with those that were left open. How often are they getting infected, or did it work, that all the washouts that they did and everything they did to prevent it? So here's an example. On 8/1, a patient presents to the ED with an acute abdomen and is admitted to the OR on the same day for a coloresection. They found peritoneal abscess was noted at the time of the surgery. The abscesses were drained, and thorough abdominal washout of the incision was loosely closed with some packing between the staples, and a JP was placed in an adjacent stab wound. The patient was discharged. Wounds were healing well on the 4th. On the 8th, they came back to the ED with fever, abdominal pain, and purulent drainage via the JP drain that was still in. This is reported as an SSI IAB because it meets criterion 3A. I'm sad to say I have them all memorized. That's the one where you basically have a drain that was placed in the OR is draining purulent drainage. We're talking about coming from the outside, not a localized infection. And they came in, they were symptomatic. That's criterion 3A of GI IAB. And I believe, I think Courtney can correct me here, you all were given in your resource manual the IAB definition from chapter 17. I think you have that, if you want to look at that. It's like everybody's favorite definition now that we do colos. All right. So let's, in chapter 9, again, this is repetitive, I have to take this out. We have a lot of organ space reporting instructions as well, and these are just some of them that we're going over, so please, read over after the organ space, we have reporting instructions specific to them. So when a patient has an SSI and has more than one operation, so if a patient had several NHSN operations prior to an SSI, report the operation that was performed most closely in time to the infection date. And this does not apply to that, though, 24-hour rule. I'm not talking about 2 done within 24 hours, because then you only have that first denominator in your data. So here's an example. If you have a patient who underwent a colo on 2/14, 1 week later when they're still in the hospital, they go back to the OR and they have an API via the same incision, and they develop an incisional SSI on 2/28. This SSI is attributed to the second procedure, the col, not the colo. Even if you're not following that in your plan, you don't want to jump back to the colo procedure. They've had a major, another NHSN operative procedure, so you attribute to the most recent. Let's do case 9. So on 3/10, your patient is admitted and underwent a hemicolectomy due to colon cancer. The wound class was listed as clean contaminated. 4 days later, their temp is 38.7. They have abdominal pain. Ultrasonography shows an intraabdominal abscess. They take them back to the OR for an IND of the abscess. The specimen collected for culture and antibiotics were begun. The abscess grew, E. coli. They were discharged home on oral antibiotics on the 18th. Does this patient meet criteria for an organ space SSI? Go ahead and use your clickers for this. It's a voting one. Give you 10 seconds. Almost everyone's voted, I can see from my magic window here. Yep, very good. Yes. And here's the reason. You've got occurred within the proper time period. Abscess was in the intraabdominal organ space. There was actually an aseptically obtained specimen as well at that time, and they saw there was an abscess seen during, they took him back to the OR. So this can meet on more than one level. So this is, meets the definition for an organ space, and it has to then meet the IAB criteria. So, okay, so two different criteria must be met for an organ space. Your site-specific organ space, where they saw the abscess on CT and then took them back and found it, and those are the site-specific, and all those site-specific organisms are in Chapter 17, the HEI chapter. What type of SSI does this patient have? Is it a superficial primary, a deep incisional primary, SSI organ space intraabdominal, my GI-IAB is this called, or SSI, there's another one that's called GI-GIT, which is gastrointestinal. One's intraabdominal, and one's their GITs are gastrointestinal. Which one do you think this patient met based on the findings? Okay. 10 more seconds. Almost all the votes are in. Very good. I was afraid now there's that maybe that would trick you up a little more than it did. Not that I'm trying to trick you. This is a GI-IAB intraabdominal, which means, and this is cut at the top of each of these definitions in Chapter 17, it tells you where to apply this definition. So a GI-IAB infection means it's not specified elsewhere under gallbladder, bile. It's an infection that's not specified elsewhere, such as these are our gallbladder, your bile ducts, liver, excluding a viral hepatitis, your spleen, your pancreas. All these infections are in the intraabdominal space. Peritoneum, subphrenic, subdiaphragmatic space, or other intraabdominal tissue not specified elsewhere. So the intraabdominal infection has to meet one of the following criteria. The patient has to have an organisms or an abscess. Now, we did add this. Last year, this said organisms cultured from purulent material from the intraabdominal space, but a lot of times they wouldn't use the word purulent, even though they were saying it was an abscess they were culturing. So we added this, we did very little changes to Chapter 17, but we felt this was important enough with how heavily this criteria is used to make sure we know that if they go in, they've seen an abscess and they're culturing the abscess and that their organisms found, that will meet criterion 1. And then the next one is they have abscess or just other evidence of intraabdominal infection during invasive procedure. So they can go in and see a really bad abscess or really inflamed peritoneal cavity, and they cannot culture, because I have, this question's in my mailbox right now. Can you have an SSI and not have a positive culture? And hopefully by you seeing this, you absolutely can meet SSI criteria where a culture is not sent. And the last one is the one that they have to have 2 of the following signs and symptoms: fever, nausea, vomiting, abdominal pain, or jaundice, and one of the following. And these are, I'm not going to labor over these. You all know these. We didn't change these definitions at all. And we'll be touching on a couple of these in some cases coming up. All right. So what you think about is the really most specific ones are up top. And when you get into maybe a little less certainty, is this really going to meet GI-IAB? We want to see some symptoms in here as well as this, you know. So these, as you see, there's no symptoms associated the patient has to have. This asterisk here means with no other recognized cause. So that is a very much of a clinical thing you have to look at based on the case. Now, why was this not a GI-GIT? The person had a colo procedure. We operated on their colon, so why wasn't this a GI-GIT? Well, because this was not an infection, the GIT tract, if you look at it, is really for things like the stomach, the actual colon itself, things that are a part of the actual tract. They did surgery on that, but it actually expanded and went in to cause an infection in the intraabdominal area. So therefore, the IAB was the appropriate choice for this kind of general intraabdominal infection. Let's change the scenario one more time, and let's say at the time of the IND, it was discovered when they took him back in that the patient had suffered an anastomotic leak from which all these abscesses had developed. Does this change your determination of this being an SSI IAB? No, this was not a voting. Although an anastomotic leak is a complication of the surgery, the fact remains that this patient meets the criterion for an SSI. If the surgery hadn't been performed, there'd be no anastomosis that could have leaked. It's a complication that caused an infection. That being said, does every single anastomotic leak cause an infection? No. You can get that patient there super early. It can be a tiny leak, but they're still becoming symptomatic, and they get to the OR, and they don't meet that criteria. They still have to meet the criteria. They often will, but it isn't an automatic that you say, oh, anastomotic leak equals SSI. All right, let's try this one. Case 10. We have a patient has an abdominal hysterectomy on the 22nd. They come in on the 1st with pelvic pain and a temp of 38.4, and the MRI is done. It reveals there's some sort of fluid collection in the deep pelvic tissue. The surgeon opens the patient, goes back to surgery. They open the wound on the OR and drain purulent fluid. Specimen is sent to the lab for culture, and it's noted by what the lab says as an infected hematoma. So maybe that fluid when they got in there was that dark chocolatey brown. Antibiotics were begun, and the incision was closed back up again, and that culture was positive for Pseudomonas aeruginosa. So what should be reported? Should we report an intraabdominal organ space infection, an other reproductive organ space infection, or an other organ space endometritis infection? What do you think? This is a voting question. Go ahead and use your clickers. A lot of discussion on this one. That's good. All right, 10 seconds. You've almost all voted. Okay, now I knew this was going to cause a problem because, not a problem, it's a teaching opportunity. Because I think that when I was an IP, true confession, I think I was calling these this, and I was calling them IABs. Here's the reason, and this is again getting back to why I read you the IAB definition, and especially with HIST being reportable. IAB or other intraabdominal tissue or area not specified elsewhere, that's the IAB. Now let's go to the OREP. Here's our OREP. I've got it cut and pasted in front of you. An OREP is other reproductive. What was done for this patient? She had a hysterectomy, and where did they find that fluid collection? Deep pelvic tissues. So when you find those deep pelvic infections showing up, hopefully not very often, after your hysterectomies, go look at your OREP definition. That's where they should be being attributed to. It doesn't mean every hyst produces a deep pelvic. It can have caused a general intraabdominal if it progressed. But if that's what this is, and I see a lot, you need to go here. And honestly, when you look at the OREP definition, it is it's easier to hit than an IAB, honestly. It's just when you look at it, you're going to hit this more easily. And you may have been missing some of your true other reproductive after hysterectomy cases if you haven't been remembering this deep pelvic tissue falls under that. Let's do case 11. You have it's 5:15 in a 5-year-old female undergoes an abdominal hysterectomy and a colectomy is performed through the same incision. And both of these procedures are in your monthly reporting plan in May. Which one should you enter into NHSN since they did both? You got it. Both are entered. And we've covered this so much. I'm just telling you, I've really tried to help you really become best friends with reporting instructions. So this is reporting instruction number 3. I just cut and pasted it from the denominator reporting instructions. Now, let's continue this case. This 45-year-old female, she underwent the abdominal hysterectomy and the colectomy and was performed through the same incision. And on 5/19, she spikes a temp to 38, has abdominal pain and emesis. Ultrasound shows fluid collection in the abdominal cavity. Fluid specimen for culture is obtained by needle aspiration. And on 5/20, that culture grows ephysium, many neutrophils are seen, okay? Is this an HAI? Yes. Is this a deep incisional primary, a deep incisional secondary, an SSI organ space site-specific IAB? This is an IAB, but there is no SSI infection. Okay, 10 seconds. Very good. This one was not, you got it. And which procedure is this SSI attributed to? Hist, colo, or both of these? Do you have to attribute it one to each? Get your voting. All right. 5 seconds, because I can see almost everyone's voted. You guys are so quick on the draw here. And you're right, it's attributed to the colo. And what's our rationale? Remember table 5 here, okay? We're going to go on to table 5 where you had 2 procedures, just a general intra-abdominal infection. You cannot tell which one to attribute it to. And again, this is from our reporting instructions here. You need to go to table 5 and look where the colo is and look where the hist is, okay? So it needs to be attributed to the colo procedure. Much higher risk in terms of what may have caused an infection. All right, case 12, I think we're getting close to the end of our cases here. So this is on the 15th of January, a 60-year-old female was admitted with acute abdomen, sent to the OR, and the finding was a ruptured diverticulum with fecal contamination of the abdominal cavity, wound class contaminated. Colectomy is performed with a colostomy formation. The incision is loosely closed with staples to allow for drainage, and antibiotics are ordered. So on 1/19, the patient is progressing well and is afebrile and is discharged home. She did pretty well. She got home in 4 days. It must be a stellar facility. That's usually a pretty complicated recovery. But anyway, she did. She comes back, though. It's now 10 days post-op, and she presents to the ED with fever 38.5, abdominal pain. The CT scan is suspicious for some possible small abscesses in the intra-abdominal space. The MD starts some antibiotics. The patient is discharged. No cultures were obtained. And the discharge note states patient returned with possible intra-abdominal abscess. We also see a lot of these little squishy kind of notes. So, whoops, I went the wrong direction. Okay, so should this patient's chart be reviewed to see if they meet criteria for an organ space SSI? Yes. Hopefully you found this somehow, that this patient came to an ED. Hopefully you're reviewing ED notes. Your SSI surveillance should not just be driven by a positive culture result. I hope after hearing this, you're getting that you have to do more. That's not going to be enough, because for every single one of these criteria, you do not have to have a positive culture result, and you can still meet your SSI criteria. So you will be found, when the validating starts, to be under-reporting, and some of you are already being validated, I shouldn't say starts, if you get picked, be under-reporting if you don't have methods beyond, hopefully you have methods beyond looking at just your lab's positive wound results. So, yes, you all agreed, you voted. Yes, 100% of you. We need to have found this chart, hopefully somehow. Now, does this, yes, okay. This is the rationale why you want to look at that chart. In organ space, it doesn't say you have to have absolutely found it. There's enough suspicion with saying this person might have an abscess that it warrants you looking beyond just the general organ space definition to see, does this patient meet criteria for an intraabdominal infection based on Chapter 17 HAI criteria? So let's go progress here. Does this patient meet site-specific criteria, a specific type of infection to be reported? And start looking at the case and see if you think this will meet criteria. I'll give you about 10 more seconds. This one's a little trickier, I will say. All right, I'm going to close the voting. And the answer is no. And we're going to go through why it's no. You ready? And here's how you should be do this. Get your criteria in front of you, okay? All right, settle down. I'm going to go through it. You ready? Simmer down. Here we go. Does this patient meet criterion 1 of an IAB infection? No. Read that. Does this patient meet criterion 2? Seen during an invasive procedure? No. All they did was an imaging test that said possible small abscesses. Let's look at number 3. Did this patient have fever and abdominal pain? Yes, I highlighted those. Did they culture anything on this patient? No, so you don't meet 1. Did they culture 2? No. So what are you stuck with looking at now? 3. 3 means you have a CT, you have an organism in the blood, and you have imaging test evidence. This patient would not meet criteria unless that patient had had an organism in the blood that would have pointed to it. And this is where people, if they're not applying the definition, just say, oh, they think it's a possible abscess, let's call it an IAB. It's so little. I mean, there were some possible small abscesses. They didn't drill deep enough to know if this actually meets criteria. So you also don't want to be overcalling your infections. If all you have is an imaging test. You got to remember this for IABs, and there's nothing more. And they don't do an invasive procedure, and they do nothing but a imaging test. It's not going to meet. And I want to allow enough time for questions, so I am going to skip case 13. It's there. It's nothing that exciting. No, I'm just... because that was the last case, but I want to get into the last section so I can leave a few minutes in for questions, and I'll be able to hang out after Maggie's section if you need to find me. I don't want to answer questions because mine leads right into Maggie's, and you don't want to miss that. So I will answer before Maggie's, and then I'll hang around after Maggie's. I'll come back up front. So this is just completing the event form. You've done this. This is my hang in there, guys. We're almost done. And this is what you're going to complete for every SSI. This is your patient information, nothing fancy here, but there's a new thing I want to point out. Did you notice on the form? Medicare number, required as of July 1st of 2014 for events. That's a key word, events that are reported to NHSN for acute care facilities that are participating in the CMS IQR program. This is a new CMS rule. We've been telling you about it, but it didn't go into effect in January. Now, what this is going to... mean is, because I've been getting this question, they really wrote the rule that it's for events and not just SSI. These are your events you're reporting. You're doing colos, your hist. But they didn't write it for procedures. So all those denominators you're sending over, because people are saying, do I have to have this Medicare number on all my denominators? No, it's events. So at this point, until they change the rule, CMS just wants it on your SSI. Well, I mean, for what I'm telling you. But this applies to all the people who've been speaking today. When you're reporting for CMS an event, like a CLABSI or a CAUTI, you're going to need to start having this number July 1st. And this gives you the details about it. I'm really good at jumping the gun on my slides, aren't I? So this is just telling you what I just said. Then you're going to note if it's an outpatient procedure or not. And again, we have that same MDR infection surveillance question. If you're not following MDR like staff MRSAs and the MDRO surveillance plan, and you kind of forget and you think, well, yeah, this is an MRSA SSI. I think I'll check yes. You'll get an error message. That's why it's smart. And it'll say, sorry, you are not following this plan in your facility. So you can't kind of mess it up because the application knows that. And then this is just your basic, put in your procedure, put in the type it is, the date of the event, and the date admitted to the facility. These highlighted fields are required. Your ICD-10 CM code is optional. You do not have to put that in. Was the patient's date of admission and date of discharge the same day? If it is, that's going to be a yes there. And then this is, are you following this plan? Now, this one I want to talk about because you all get error messages and then you get a little confused. If you have a patient, you enter the date the patient was admitted to the hospital when the operation was performed, not the date when they were readmitted. So when you're looking at a patient who had a procedure on the 1st, gets discharged on the 7th, comes back in on the 14th with an SSI, if you forget and put down their admission date as the 14th, you get a big fat error message because you can't have their admission precede the actual procedure. So you just look back at the where they were and put the admission date for when they actually did the operative procedure, and that error message will magically go away. Location field has always been optional. It isn't really work or that necessary. These are procedure-based. They're not location-based. There's no transfer rules, all that. So it's just an optional field. So this is, again, reminding you, because we use the admission date of the primary procedure that you're attributing to, not your readmission date. Because your date of admitted has to be less than or equal to the date of the procedure, which has to be less than or equal to the date of the event. Then you have to fill in your specific events. This is where you say, am I saying a superficial, deep, organ space infection? You're going to fill in which kind. You are going to need to put in which, if it's an organ space, you need to select which one. And the thing that's good if you haven't played in this is that basically we have figured that out for you. You don't have a choice of everything in Chapter 17. If it was a cardiac procedure, you only have a few choices: superficial, deep, endocarditis, mediastinitis. The organ spaces are filtered in the drop-down to be specific to the kind of procedure that's being done. So look at that and know what your choices are. I have a little cheat sheet that next to Colo in my manual, which lives by my desk, so I have looked through all these when I somehow had a minute and wrote down what is every organ space that is allowable for a Colo, what is allowable as an organ space for a hist, so that I can remember what's on those drop-down menus. It's really fast and me thinking, wait, can I call it a this? I just have it written down. Then you're going to say your site-specific, how does this meet? Why do you think this met the criteria? And you're going to fill that all in there. And then this is a required box. You have to say how you found the procedure. Was it when the patient was still in-house and had never been there, post-discharge surveillance, readmitted to your facility, or readmitted to a facility other than where the operation was performed? And again, this is where we have to rely on our IPs to give us that information that we had someone that you did a hip on, and now they're back here with an infection. Again, this is required. Did the patient have a secondary BSI? Yes, no, that's required. Did the patient die? Yes, no, is required. Now, again, I'm kind of the first one who's really going through actual entry of the form, and I want to address this. This is a required field. Back in the old days when it was NIS, and I've been there since then, been there, done that. There used to be a yes, no, or unknown, but they got rid of that, so it's yes, no, and basically what we like to say, if you see in that death note summary that the patient died from a surgical site infection, you can say yes. But with litigation and risk and everything else, that's all we're asking. Did the physician who wrote the death summary for a patient who expired say it was because of a surgical site infection? I think if they say that comfortably, you can say yes. If you can't find that that's documented in the chart, I would select no. And then lastly, you'd have your discharge date is still an optional field here. If they identified a pathogen, and do you necessarily have a pathogen when you have an SSI? No, not necessarily. You're then going to go in the back and you're going to have your drop down of what infections, pathogens were found. Now I want to point out something here because if you haven't discovered this, when you're actually in your application, now I don't know how many of you are actually in the application and entering these yourself. Some big facilities, the IP is actually filling something out that then goes to someone else who might be at more of an administrative assistant level who's really dealing with the application. But if you're not and you're doing this yourself, what throws people off when you're in the application and you're going to enter your organisms, the organism list, you can imagine, you know how many organisms we have. It opens up with the most frequently hit organisms that we think people use. So what will happen is I'll get emails that'll say, this person has Enterococcus species or Enterobacteriaceae species, and I can't find it in the dropdown. I guess it means I don't have to put this in. No, when you enter that organism list, go to the very bottom and there's a thing that says all pathogens. Select all pathogens and you really see the complete list, but we don't want to make you fight through every single one. So you'll find your less frequent oddball organisms on that list. See, I'm going to be giving you so much. I think my mailbox is going to be empty from now on. What do you think? Yeah? Yeah, no more emails? All right. Now again, and you've heard this in every single one, so I'm not going to belabor it, you need to pay attention to your alert page when you open it up. And you may get an alert that says, look, you're missing one procedure associated event here. It's like, what does that mean? So what you're going to do is go to your events, and it's going to show that it's incomplete, and it tells you that you did a hysterectomy on a patient. You have some hysterectomies you've entered, but there's been no SSIs attributable, and that's great. You did a couple, but nobody had an SSI. You just need to say that we had no SSIs attributable to this procedure that's in our reporting plan. They want to make sure you didn't forget to enter any, and especially when states and people were being validated, they really want to know that it wasn't just, oops, I forgot to put them in. It's really, no, I didn't have any. And then you're going to report the no events and click the save button. So in summary, you want to complete and enter a surgical site infection record for every procedure that's in your surveillance plan using all these wonderful instructions that I've been pointing you to. Now so it's in one spot. Here's the errata I told you about, the three things. Non-primary closure and the key terms and table of instructions, please go reprint it. It's correct. That's in there now, so I want you to have the correct definition. The not incidental to another procedure should be crossed out from Table 1 next to API. And that PJI definition, your C-reactive protein should be greater than 10, not greater than 100. So, all right. Now I want to give you a very quick heads up, and we'll probably have more details by the time APIC comes around, but what's coming in 2015? So the big thing here, and probably a lot of you have gotten this email, this is all I know right now. And maybe Dawn knows more, but this is the information I have right now about our transition to ICD-10 CM-PCS and CPT code-based procedures. So CDC is actively working. We've received some of these now. It's a huge project. We had to bring on people that were specialty coders to do this. We are mapping all of the ICD-10 CM-PCS codes and the CPT codes. We're offering dual mapping to all of our procedures for that are followed under SSI surveillance, and we're anticipating that these will be available by July of 2014, so you'll be able to kind of get a look at what they are and share with IT and do whatever you need. The ICD-10 CM PCS codes will replace the ICD-9 CM codes on October 1st, unless something changes. That's where we're still only hearing these go away on October 1st of 2014. But NHSN will not have the ability to receive these codes in our application. Think about these application bills until the January 15th release. So we can't take ICD-10 codes until January. So the guidance we're giving you right now is that the NHSN guidance for that last quarter of 2014, so it's your October, November, December, if ICD-10s roll out when they say they will roll out, is that you're going to want to not use codes, and maybe many of you don't. You won't put in an ICD-10 code because we can't take it, but you'll say this is a hip, this is a colo, and you'll have the cheat sheet by then that you'll know what your ICD-10 hips and colos and HIS are. But you just can't put the actual code in because we can't take it. And then at the time of the January release, we'll be able to accept the new ICD-10 codes. We don't want you to go back retrospectively. You don't go back to that last quarter and put them in. It just doesn't exist in our 2014 application, so you just get to move forward in 15. So you'll just be putting in procedure names for the last quarter and no codes. And we're also going to have CPT codes. And what else is coming in 2015? I want to leave 5 minutes for questions. PATOS, we've been talking about this for a long time. In 2015, new field's going in. It's on your numerator form. I love things on the numerator because we're all looking at those charts anyway. It means that this tells us, it captures a condition or diagnosis that the patient, the time they went to surgery, they had an infection. This is telling us that when that patient went to surgery, the physician documented that that patient was infected. That would be your ruptured appendixes, your ruptured colons, and all that. And there'll be a field when you're filling out an SSI that you'll be say, yes, this was present at the time of surgery. I think that will be very helpful and something you can really trust that you've looked at it and you've noted that. The last one that's going to come for HPRO and KPRO procedures, and this is going to be denominator data. This has been wanted for a really long time. If a total or partial hip revision that's being done is being associated because of a prior infection of that joint, you're going to be able to have a field that says prior infection of this joint for those joints that just keep coming in infected and you can't seem to get it cleared up. The end, and are you at the end of your rope? All right, so if you, the mics have been turned live, so if you want to come to the mic. Yes.
Hi, this is Lisa from Fairview, Minnesota. So if we have a patient that comes in, say in our colo, they've got a rupture or something like that. They come in, they have an abscess, and say we do multiple procedures over multiple days. So the surgeon goes in over multiple days and is cleaning out and cleaning out and cleaning out. Do we have to call that a separate surgical site infection for every procedure? You see what I'm saying? If they're having 5 operations, is that 5 different?
Well, I should have addressed that, and I thought I had it in here. Once you have a procedure done, and if they go back and do like an IND to that wound, which you wouldn't be doing 5 colos, or you're doing INDs, then infections that occur after that are attributable. We have in our reporting, if you do an invasive procedure at the site, like if you have a patient who had a joint replaced and developed a big hematoma, and they go in and have that hematoma aspirated, and it's not infected. It just was they had to get rid of that hematoma, and the infection occurs after that invasive manipulation. It's not attributable to the HPRO. You could have easily introduced something during that procedure. Same if they had that colo, the clock starts ticking again when they take them back and have another operative procedure, whether it's just if they find that first SSI at the IND, yes, that's yours because it's the first infection after the colo. But if they keep having them, they're not attributable back to that first colo because you've had other invasive procedures.
Okay, so would that go for any surgical procedure? Say someone comes in and they have a deep wound, and so maybe that's not reportable, but that's something that we follow. So if they have a deep wound and we keep debriding that wound or whatever over days?
That I would want more details. I'm very, very reluctant to answer an actual case without the details. So what we said that the opening of a wound and that it's not healing properly, and it's in the protocol, and it starts. You have to start doing some wound packing and wound management. That is not considered invasive. You've opened up this superficial incisional wound and you're dealing with trying to help it. That's not what we call an invasive manipulation. Invasive manipulation is going down into deep organ spaces, going down into the deep joint and that sort of thing, not the management of a wound, post-op wound to help it heal.
Okay, great, thank you.
Often they meet anyway. When they start opening them up, you're going to hit one of those because they're opening it and culturing it. But if they haven't, and they eventually do, you will need to attribute that if it's in the surveillance period. Yes?
I have a question on that same slide that you made the change for PJI definition in the HAI chapter has a typo and
Yes.
it's greater than 10, not greater than
Yes.
100. On the one before that in 3A, it says elevated serum C-reactive protein, and you said or electrolyte.
Right.
And is it and? It's printed as and, so is it or is it and?
It's or.
Thank you.
Yeah. So, okay. So there's only three. We're going to start Maggie's, and then she and I can both, we'll have more time for questions at the end, but we want to have Maggie's. Thank you.
I'm back. But you guys won't have to see me tomorrow. Well, at least not up here. So, I don't feel so sad about that. I get to relax tomorrow a little bit. Thank you, Courtney. All right. So, really, I just want to spend a few moments talking about the procedure import process. I'm not going to go into great detail about it, but really, in our past training courses, we had included this type of training in with the protocol training, and we thought, well, let's, lighten this a little bit and just focus on how the changes have impacted importing data. So I'll briefly review that procedure import process, and we're going to focus today on CSV files. We know that many folks are using clinical document architecture or CDA, but we're not going to be focusing on that today. And of course, I'll discuss the 2014 changes. Okay. So on our website, actually it's on the SSI reporting protocol page. At the bottom, we have a section called supporting materials. And in that section, we have specifications, file specifications, and resources for importing procedure data using a CSV file. We are currently updating a training slide set that will go into more in-depth materials about the process and what I'm going to be going through today. So those will be up on the website soon. In the room, can I get a show of hands? How many people import using CSV? Wow, quite a bit of people. That's great. Okay. So hopefully you're aware of some of these changes already. But if not, then that's why we're here. So this is a snapshot of the file specifications for the CSV import. We do update these as there are changes to data requirements. So I strongly recommend that you, if you have not downloaded this document for 2014, that you go ahead and do so and communicate this with your IT department or whomever it is that helps you produce this file. So, of course, you need the help from your IT staff if you're going to be importing procedure level data using a CSV file. So, I really just want to drive home the point that the procedure data that are imported must follow these specifications, okay? They have to follow the order of fields that we have specified here. And you have to actually read through carefully all the notes that are on that first page. There are a lot of notes, but those notes are there to help prevent any issues with importing your data while you're in the process of that. This is just a snapshot of what the first section of those file specifications looks like with the data fields. And what I want to point out here is that these are in a different order than how they appear on the actual data collection form. So that's why you have to follow this order and not the order on the paper form. In addition, we provide specifications for the values that are allowed, the data format, and the requirements, and these must be followed. So you cannot use your own format for wound class or ASA. You have to follow the values that we have here, because basically this is taking the place of data entry. And when you manually enter data, you don't just type in the wound class, you actually select from a list of values. So that's why you must use what we have here. We do have some hospitals that use custom fields, and you can import custom fields with your procedure data file, but you have to make sure that those fields are set up in NHSN prior to importing any of these data. So that's just a heads up. The data requirements that we provide in the specifications document assume in-plan reporting. Just like when you look at the paper form and we have all those asterisks next to certain fields, all those fields and requirements assume that you are following that procedure in plan. And so the same goes for importing data. However, we do have some fields labeled as optional for import. And optional for import is a field that is essentially, at the end of the day, required to have a complete in-plan record. However, these fields were marked as optional for import because they were thought of as not being available directly from OR systems. And so you may have had to use a different system and it was too difficult to bring it into the import file. So we said, okay, you can bring these data in with these values missing, but at some point you'll have to complete it manually through our data entry screens. And we'll provide a list in our data entry screens of your incomplete records. So I really want you all to think of our file specification as a companion to and not in place of the full requirements for procedures as we've described in our tables of instructions, okay? These do not replace anything. They're really meant to just be a companion to that. So in addition to reading through the protocols for surveillance, the tables of instructions, the requirements on the form, our key terms, if you're importing data, you need this in there as well. It's all one package. Okay, and I am reiterating that point here, that it is a companion to our protocol. And so all of those requirements must still be followed. Let's talk a little bit about the changes for 2014. I know I mentioned some of these this morning. I know Janet mentioned some of these, but repetition is good. So wound class for procedures that have a date of 2014 and forward. You can no longer report these with a wound class value of U or unknown. For the spinal level variable for fusions and refusions, again, you can no longer report these with a value of not specified for 2014 and forward. And the same goes for type of approach, where you can no longer report not specified. For type of approach, we made a couple other modifications. The value of transoral is new for 2014 procedures only and going forward. And lateral transverse is an old value that is basically retired. So you can only use that value for procedures dated in 2013 and earlier. Of course, we have our new type of HPRO and type of KPRO fields. So previously, we just had two variables, type of hip, type of knee, and that was it. Well, now we have additional fields looking at specific types of total, hemi, or resurfacing procedures. So once you import a value for your hip and knee that tells us the type, you will also be required to complete one of these bottom three, either total, hemi, or resurfacing. These are all separate variables in your file specifications. So if you are importing these types of procedures, just know that you'll need to complete that as well. And we only need values in one of them, not all three. Course height and weight, as we discussed this morning, or as Janet discussed this morning. This is required for all procedures dated with 2014 and forward. However, we marked this as optional for import. So this means you can import a file with these values missing, but you must complete these manually through NHSN in order for the record to be complete. Okay, so just keep that in mind. If you have a large file that you're importing and you decide to keep these missing, you will have to complete them at some point. And of course, diabetes is required for all procedures beginning this year as well. Closure technique, again, required only for procedures dated 2014 and forward. This is also marked as optional for import. So again, you can import these data with this value missing, but you must complete it at some point manually through NHSN. And the values that we allow are PRI for primary or OTH for other than primary. In addition, we did slightly change the order of the fields. We had to shift everything down by 1 or 2 variables. So this applies to all procedures, regardless of the procedure date. So if you're still needing to import procedures from 2013, you have to follow this order. And I believe it is just the addition of a column if you're using an Excel type CSV file. So you may want to hand those specifications over to whomever's helping you create this file and just make sure that everything's in order. With this, just know that in our supporting materials on that SSI website, we do have a sample file. And in that sample file, we do include a header row as the first row that includes the variable name so that you know what data are supposed to be in each column. Now, you cannot import a file with those variable names in that header row, but if you're looking to make sure everything's in order, you can kind of copy that in to your file just to make sure everything's okay, and then you can remove it before importing your data. So if you're not familiar, in order to import a file, once you've created your file, you can import data by using the import-export option in NHSN and selecting the import type of import procedures, comma delimited. You'll be asked to select your file, which is a CSV file, and then you click submit. And you'll notice when you submit, you'll see a progress bar appearing. And depending on the size of the file, it may take a few moments to get the entire thing into the system. So just be patient. But once the entire file has been submitted, and actually, you know, now that I'm reading this, I kind of don't like the word submitted because no data are saved at this point yet. It's really just... I don't even know what the right word is, but they're not yet submitted. So what we're doing is we're trying to just transfer those data into this temporary holding place so that you can review and make sure everything's good. You can have up to 5 tabs when you import your data. There are inserts, bad data, updates, multiple records, and duplicate data. Today, I'm just going to focus on inserts and bad data. The other 3 will be described in the slide set that we'll update on our website. So the inserts tab is the good tab. That means everything's cool. You can import the data as they are with no additional modification. And what we do is we try to provide you with the information for all these procedures, but because you can import so many different data fields, it's very wide. So you have to scroll your window over if you want to see some of the additional information. However, if you click Edit, it will bring up a very short screen that's more vertical with all of the data fields completed for that record. But at that point, if you make any changes and you click Save, it's still not saved in NHSN. It's just in this holding place until you're ready to finish the import. The bad data tab is just as it sounds. It's bad data. So we are not going to let you import any records that are labeled as bad data. We try to do data quality checks through this and prevent any potential errors. So if you're using the wrong value for a certain data field, or if the procedure date is in, 1909, we're going to try and prevent that from happening. But what I want to let you know is that if you see this bad data tab, you cannot import anything. So it is all or nothing. You want to make sure that you are left with just an inserts tab or an updates tab. If you have a bad data tab or anything else, you are not going to be able to do any importing. So we recommend that if you have a lot of records in the bad data tab, stop what you're doing, go back to the original file that you have, or go back to the person who's going to help you with these data and get it fixed in the source file, because it could take you a lot of time to update these records. And again, nothing is saved at this point. So if you leave your desk and you're logged out of NHSN, it's all gone. Okay, so this is just kind of repeating what I had to say just on the last slide. So you should only have the inserts or updates tab, and once everything is good, you click update at the bottom of that list. And then when all records have been imported, you'll see a message confirming that it has been successful. You'll see that nice little green check mark that you often see when entering data in NHSN. So just a few helpful tips. Facilities will be stopped if the data are not in correct order or if they do not leave empty placeholders for optional fields, okay? So there are a lot of optional fields that we allow you to bring in, such as custom fields. And when you're looking at the data in Excel, you have to leave those empty columns for those optional fields. Otherwise, everything's going to be shifted. And hopefully this goes without saying, but, and I know all of you in the room and those watching on the web streaming who this is your job, your IPs, you already know this, but the people who help you may not know this. So it's extremely important that the same definitions and protocols are followed, okay? So there are many times where your OR staff or your IT staff are not aware of our standard CDC definitions for these data fields. So it requires a lot of teamwork and communication when you're first getting started with these files, or if you need to modify the data in these files for new protocols like we're seeing this year. Your data managers, your IT staff, OR staff, they can email NHSN directly with questions if they have any questions about what something means. They're free to do that if they'd like. It's equally important for you as the IP to understand the data elements that are captured from your OR or other systems as well, making sure that the procedure duration is in alignment with our definitions and that other elements are also in alignment. Also, make sure your patient IDs are correct. So, we notice that some folks may have trouble linking SSIs because the data that were imported may be missing leading zeros for your patient ID, and when you're entering the SSI, you're including the leading zeros. So even though all of these patient IDs here look very similar to us, to the application, those are completely different patients. Those are different numbers. Anytime you add leading zeros or dashes or any sort of prefix, that's considered a different patient. So, make sure you're aware of how the format of those patient IDs are being used in that import file. And of course, I know this is an import talk, but I have to talk about checking the data. I'm a data girl. So I recommend that data are checked to ensure accurate data have been collected, that the data that you are importing do meet our protocols and everything matches up. You don't have to do this constantly, but you should do some sporadic checks on this. You should especially check your data if any of our definitions have changed or if you're aware of any changes that occurred in your OR system, just to make sure everything matches up. And of course, you can utilize our analysis output options to help accomplish this using line lists and frequency tables. We also have a variable called imported, and you can add this to the procedure list or frequency table to look at specifically those records that were imported to us, especially if you said, well, you know what, we're brand new to this. We're going to try this with one procedure category just this month to see how everything works out. You can run analysis only on those imported records. So these are links to our resources related to importing the data. Again, we will be updating a full slide set that will include much more detail than I went through today. So I thank you for your attention. I'm happy to take questions, and Janet is coming up as well for questions. But before I forget, I was asked to make an announcement that folks here from Oregon can meet over in this corner up here at the very beginning of the break, which is coming up in about 10 minutes. So if you're from Oregon, please meet them over there. And all right, questions?
So I'm going to go ahead and give a shout out to people that are listening web streaming because we have a couple questions and we haven't really had those. So I'm going to send a shout out to Elaine Decker. She's listening from San Francisco General Hospital, and here's her question. It's a little longer, the question, but I'm going to give you the short answer. She wants to know, is there a way that if we know the BMI, we can just enter a BMI and not enter height and weight? And I've been asked this already, and the answer at this point is no. We really want to know that it is a correct BMI and that it has been calculated using our internal calculator. So we do want to see the height and the weight, and then our application will enter the BMI. So I just want to give her that answer. And then I have one other quick question. This is from Beverly Sturgill from Carilion Roanoke Memorial Hospital. Are you still on the line, I hope? Didn't know if they could answer. But anyway, this was around what I said about the reporting instruction, that if they are using ICD-9 codes and they should any XLAP be reported regardless of whether it results in a procedure from another category. Now that was the old one. You have to look into it, see if another procedure was done, don't report the XLAP, okay? But we took that rule away to try to simplify. So if you're just dealing with line list, so yes, if you get a line list from your OR, from your coders, however you're getting your line list, and you have an XLAP and a COLO, put them both in. Now, think of an XLAP and a COLO. If you develop an SSI, it's never going to be attributable to the XLAP because the COLO is deeper, but you've got that in your denominator data, all right? So, and sometimes they just do an XLAPs, and those will be in there as well, all right? So I just wanted to clarify that. I'm going to, I think that was the only thing I needed to clarify. Okay, in the back there, hi.
Hi, Janet, Joan Hebden. I have a comment and then a question. I am a bit concerned about the optional field for ICD-9 on the surgical procedural form. And the reason relates to some of the auditing I've performed, state auditing, that would suggest that there may be procedures being placed in the denominator for colons specifically that shouldn't be there. And I wondered, when you don't have really any way to know that if you're only entering the NHSN procedure code.
That's a great question. And I can tell you that I was in a big meeting room last week dealing with that exact question of when and if we're going to go to a process where we are more code-based, and we would require that the primary ICD, at that point it'd be 10 code be entered. And we're not there yet, but we are very aware of it as an issue and are working at it at a high leadership level right now.
Yeah, because many times the OR databases that you're creating your CSV files do not have that piece of data.
Right.
That isn't tagged on to the end when it goes to billing.
Right.
So it really becomes a big concern in light of the trajectory that we're on about public reporting, because I can see SSI reporting increasing dramatically in the next few years.
Yeah, I'm a proponent of that. We're moving that way, and I will take your feedback definitely
Thank you.
back to our group. Yes, on the left.
Hi, Janet. Thank you. Shannon from San Diego. And I have a question. I've been emailing a surgeon, and I know we don't take what surgeons say. So I've sent him the definition. He did a fusion procedure and took a patient back and did an IND of the deep subfascial thoracic postoperative posterior spinal wound. I wrote this down. And then he found to have an opening in the inferior part of the thoracic wound that appears to be deep and subfascial. He cultured multiple layers of that incision, superficial and deep. However, the deep cultures were negative and the superficial culture is positive for Candida. And he claims since the superficial culture was positive, then it's a superficial infection, yet the operative descriptor looks like it's a deeper infection.
Yeah.
So
yeah, you've got it correctly. If it's meeting the deep, you wouldn't base it on just where the findings because of a Candida in the superficial area. If that infection progressed into the deep level, regardless of if the culture was negative, you don't know if it's a result of antibiotics. If it's meeting, there are culture negatives that will not meet. So you just have to, now that I've showed you those definitions of opening and a culture negative, that make sure you're not hitting that definition. I would love to talk to you afterwards. I'm extremely visual. If you could see how I work out these questions that come to me, it's very difficult to do an exact case standing without me mapping out date of procedure, date of symptoms. I like to really see them all. So, but I can talk with you if you want to make sure I've got the description right. But again, I would prefer to not actually answer like case questions because I need to see those in writing, so I make sure I have all the details.
Okay,
but
thank you.
You can grab me afterwards. Yes.
Ruat from Primary Children's. I have a question about height and weight for all procedures. So in our NICU, these babies can stick around forever because it's a surgical NICU. What height and weight are we using? Birth weights or at the time of the surgery?
Yeah, it's most recent. When you look at the definition, it's the height and weight most recent to the operative procedure. So it's not like some of ours state their birth weight as a category they've into, but for this, when you look at the reporting instructions in the table of instructions, it's most recent that you have to that operative procedure.
So even if they haven't weighed it, weights we usually get, but maybe we haven't measured their length for a long time, we might have a length that's off.
Well,
no
again, if the baby's right there, there isn't any problem. If you realize they haven't been measured in a while, you can add, especially if they're there a long time, you might have 4 more inches. So, but I'm just saying, the baby's still there. You could probably stretch that little tape measure out and see what they're doing now.
We just don't get our procedures until after they've been coded because it's all done electronically.
Then you're going to have to you'll just have to take then what it is the most recent, and that's where you can again have an education opportunity for folks that know this is for risk-adjusted data and say, can we start having in some checklists, pre-op checklists, that we've got a recent height and weight, and it can work really well just at the bedside pre-op level.
Okay, great.
Thank you.
Hi, I'm April with Banner Health. Mine's a NICU question too. We do some surgeries in the bedside, the bedside in NICU. And I noticed in your definition you included operating suite, so to speak, and those types of rooms that meet that criteria. So does that exclude those surgeries that are done within the NICU because it is not an operating
Yes, that's a great question. And I've had that already a couple times because with the little babies, they often, the ones I'm seeing coming in are cardiac surgeries and they can't close them right away due to swelling or whatever. And so they have to leave them open. So that is in your denominator as a card with an open. And then they close that incision a week later, a few days later at the bedside. So what's happened now is you have done a procedure that's It's an invasive procedure at the bedside, so the clock stopped ticking, and if after that closure at the bedside occurs, that baby develops an SSI, it is not attributable to that card that was done in a perfect, beautiful OR setting, because you did an operative procedure at a bedside that was not an OR.
Okay, so we exclude those. Thank you.
Yeah.
I have a question about a podiatry procedure. Would we follow that for 30 or 90 days if it involves an implant?
Good question. I am 90% sure, but again, I'm very ICD-9 code-based, and implant does not matter. Everything, podiatry procedures are all, I can answer that actually. Okay, first of all, it's not because there's an implant. Podiatry procedures are not in Table 1. If they even are an NHSN operative procedure, so what you want to go do is look at that wonderful ICD-9 mapping list I showed you. It's very likely that they're a big no, and you wouldn't be calling an SSI. If they happen to actually be in the other OTH category, all of those are only followed for 30 days. Regardless, remember, implant doesn't come into effect in terms of our surveillance period anymore. So everything in that 30-day list is 30 days, and you'll see at the bottom of it, OTH other. They're all followed for just 30-day surveillance period. Okay?
Hi, I'm Brenda from Western Maryland Health System. I have a very simple question.
Mm-hmm.
Do we have permission to use your son's beautiful illustration about the closure?
I will have to tell him that, I don't see any reason. If you have an ability to snag it, go for it, unless there's someone can tell me that I'm telling you something illegal. Where's Courtney? Can they grab it? I have to put a shout out to him. I'll call him tonight and tell him up there in New York City doing his. Thank you.
Hi, I'm Joelle, and I'd just like for you to re-clarify around the surgical site infections for organ space and C-section that endometriosis can be possible for part of the diagnosis.
Oh,
correct?
absolutely. If you look at that other evidence on exam that the patient may have an infection, that's going to be things like really fever and extreme fundal tenderness. And then you'll go look at your endometritis definition. If it admits, you call that an organ space. Yes.
Yes, Kathleen Kwan from UC Irvine in California. Actually, may I ask a question about a CDA methodology of procedure upload?
I'll be honest with you. I can try, but I am not a CDA expert.
Sure.
My colleagues, Paul Malpede and Mindy Durance, actually.
No, this is a conceptual question.
Okay.
So this the CDA upload, which is done through usually a third-party vendor, does not allow for upload of non-required fields or custom fields.
Right.
Which makes it basically useless if we want to use it for physician-specific follow-up.
So for like surgeon codes?
Correct.
Okay.
Will there ever be a time when we will be allowed to do that? Because it really diminishes our ability to use that methodology, which is very helpful in capturing missing data and things like that.
Right. So excellent question. I know that we've been asked this a lot. I believe they are trying to move forward with that, but I don't know what the timeline is for actually allowing it on the NHSN side. So I can't answer it definitively. I just know that from our side, we're trying to make that work. I just don't know at what stage, because there's only certain points in time that we can allow updates for CDA. I think it's just about, well, actually, I don't even want to say when. I don't know.
But the intention is to allow.
Yes. And so actually what I can do, I'll make a note, and, for our next newsletter, perhaps I can ask my colleague Paul to make a CDA update in the newsletter just to let everybody know how we are going in that process.
That'd be great.
Is that right? All right. Thank you.
Thank you.